So the next talk is the fundamentals of vascular surgery. When do vascular trainees achieve basic open surgical competency? This is being given by Dr. Malachi Sheahan from Louisiana State University Health Sciences Center in collaboration with his colleagues from Stanford, University of South Florida, University of California, Los Angeles, and Houston Methodist Hospital.
Good afternoon. This talk was originally slated to be presented at the VAM last June, so it looks like we passed up an opportunity to not go to Toronto for an opportunity to not go skiing. Some of the models you'll see today were developed with assistance from W.L. Gore and Symbiotics. However, none of the authors have any financial stake in the fundamentals of vascular surgery system, and none of us stand to gain financially from it, probably because we're not very bright. Europe is well ahead of the United States in terms of a fundamental skills assessment. It's been part of their board exam for over 15 years. But what works in Europe might not work here. An end of training skills assessment is problematic. What do you do with someone who fails? What form of remediation can you offer? And what would it say about their opportunity to operate independently? And furthermore, there is no evidence that U.S. graduates have a widespread lack of fundamental technical skills. So what need would we be addressing? What we've come to realize is that this system can be best served early in vascular training, where we hope to improve the basic technical skills of our younger residents. We sat down and developed these models many years ago. In doing so, we broke down complex endovascular and open surgical procedures into individual steps. But what we realized is that not all surgery is like baseball. Not everything can be broken down into simple skills. Throw the ball, hit the ball, catch the ball. Vascular surgery, especially open vascular surgery, is more like basketball, a complex series of movements that when broken down too much, start to fail to make any sense. So our models incorporate multiple skills at the same time. The first model we developed was the end-to-side model. Very simply, the trainee is given two 8mm grafts and asked to perform an end-to-side anastomosis. Here the trainee is judged on their ability to size the anastomosis, to perform the suturing, and to perform the knot tying. The second model is the patch. The trainee is given a 10mm PTFE graft with 4 hash marks stamped on it. The trainee is then asked to form a patch by cutting through each of these hash marks and then suturing that patch back to the graft. Here, one trainee struggled with everting the edges, and here is a novice who failed to complete the procedure altogether. The last model we call the clock face. This pattern is printed on a PTFE sheet, and the trainee is given an SH needle and asked to suture from the inner circle to the outer circle around the clock. This judges their ability to handle an SH needle in a wide variety of angles, such as might be required to perform a complex open aortic repair. In real life, it looks something like this, with the trainee passing the SH needle from the inner circle to the outer circle. The needle will only pass exactly if the trainee holds the needle at the proper angle, at the proper position on the needle. A finished model may look something like this. Trainees are scored based on time, errors, and accuracy. The initial model was a poor discriminator, so we shortened the time period to 5 minutes and added this tube to give it some depth. These models were all validated and presented at the VAM in 2013. Since that time, we have tested hundreds of vascular trainees. In order to be included in this study, the testing had to be performed at an ACS-accredited institution, all assessors had to be previously validated, and all assessors had to be blinded to the trainee level. The testing was performed at our center at LSU, as well as the Mighty Center in Houston Methodist and the Camels in USF. Trainees were then paired. One trainee performed the procedure while the other acted as a passive assistant. In order to show you how long we've been doing this, I have pictures here of young Murray and young Jason Lee. So all scoring is performed live, and then the assessments are blinded. As might be expected, since all of our assessors were previously validated, the inter-rater reliability was very high. The assessors used a global rating score as well as a global summary sheet. We tested 313 trainees, and as you can see, every PGY year in both integrated and fellowship is represented, as well as a large cohort of medical students who act as our novice group. Internal consistency was high, which means that as a trainee performed on one skill, they performed similarly on another model. Trainee scores correlated well with their experience, whether that was measured in time spent on vascular surgery or or number of cases performed. And here, as an example, you see the Enticide scores for both the global rating score and the global summary, and all correlated well with both the trainee PGY year, the trainee experience in time, the trainee experience in number of cases, and also the trainee self-reported confidence. As anyone who's used this particular recording system can tell you, practice makes perfect. Each model could independently and reliably discern junior trainees from senior trainees. And looking at passing score, you see that on the clock face model, the passing score gradually improves by training year. However, if you look at the early training, you see large error bars. What that means is even though a junior trainee would not likely pass this, with enough experience, they absolutely could pass this test early in training. And here is the crux of it. Looking at the PGY3 integrated residents and the first year fellows, we see an opportunity. A PGY3 resident has only about a 40% chance of passing this fundamental skill assessment, and a first year fellow has only about a 63% chance of passing. We believe we can improve the learning curve and shift these numbers over. So where are the gaps in training and where are opportunities? We believe that all vascular program directors do an excellent job in training their residents, but there are gaps. Fellows have a variable experience in general surgery and vascular rotations, and integrated residents have a lot of general surgery and non-operative rotations early in their training. Everyone has duty hours limitations, and there are decreasing open case volumes of vascular surgery everywhere. So we believe that instituting this system early in their training can allow vascular trainees to master these fundamental skills, so when they get to the OR, they can learn the more complex movements such as vessel exposure and dissection. Our next steps, we are currently operating 10 pilot programs. We're getting the materials now. We have an endo model we're incorporated, and we're working on automated scoring with engineers from Clemson and Rice and also those in Europe. In summary, the fundamentals of vascular surgery is a validated exam of technical skills, but less than 40% of PGY3 integrated residents and less than 70% of first-year fellows can pass this exam. We believe there's great potential to shift this operative learning curve to earlier in vascular training. Thank you.
Thank you so much for that amazing work. I think it's so hard to actually standardize training and much less standardize the ability to quantify where everyone is. There are some questions coming through on the chat. One is from Dr. Smeeds. His question is, did you validate these fundamental skills on attending physicians? Do attending physicians pass these scenarios easily?
Hey, Matt, what's up? Thanks for calling in. Yeah, we did. We did a lot of testing early on. We presented that way back at the VAM. We tested a bunch of attending level surgeons. I forget, what was the second part of Matt's question?
Do attending physicians pass these scenarios easily?
Yes, they do. There's always a little bit of getting used to a model, especially with the clock face model, because we don't tend to suture in that manner. But yeah, with a little bit of practice, I've never seen an attending fail, although I would like to, because it's been subject to ridicule. But yeah, expert level people can pass it. And so, but that's the point, is that I've had medical students pass as well with practice. So there's no reason, you know, this all has face validity. If you look at this, this looks like what we do in the OR for the most part. So why shouldn't our trainees be able to pass this early? You know, we read at home, we study Rutherford. If everybody was failing the V site, we would certainly have them read more. So why not have them do this stuff more so they can, you know, acquire these competencies much earlier in training?
Another question coming through from Dr. Amendola. Thank you for your important work in education. Do you think this test could be used to screen applicants to training? And do you plan to use this test in a repeated fashion as a milestone assessment?
So the second part first, we believe that, and we're working with the VSB and the APDVS, that this exam should be able to be passed in the second year of training. And then once it's passed, it's a milestone that should not have to be reachieved. So the goal is get ones and twos to pass the exam, and then you don't have to ever do it again. And then the first part was, I'm not good at remembering multiple questions.
Do you think this test could be used to screen applicants for
So
training?
I have a pet peeve about this. I do not think that, when people come, so we're right in the middle of interview season now, and I always tell people the thing I pay attention to least in letters of recommendation is technical ability in medical students, because that's our job, is to train them that. So I look for people who are smart and hardworking, because you can't fix that. You can't fix lazy, and for the most part, you can't really fix, lack of intelligence. So our job is to teach people technical ability, and I've never had a trainee who we couldn't get that done. So I don't think it should be used, because I think that's unfair. People learn at different speeds, and that's clear if you look at our error bars. There are definitely medical students who can pass this, and yet there are fourth-year residents who can't. And so but at the end, nearly everyone can. So we can get people there. So I don't think you should screen applicants to vascular based on technical ability.
Just as another question, in your perfect world, when this comes through and we implement this, when you do identify, I guess, levels of training or even specific residents that need extra help, what do you think is the most effective way to teach and then intervene at that point? Would it be protected time? Would it be one-on-one, even in the context of, in a world with a decreasing number of open cases?
Right. Well, that's kind of the point, right? So decreasing open cases, decreasing duty hours is, I'm literally holding a rider right now, this should be all the time. When you're a medical student, you're gung-ho. What'd you do? Anytime you had a downtime, you took out a string and started tying knots. So this stuff should be everywhere. That's what we're trying to get. It is everywhere, available to everyone, and we can get it cheaply. And so that, just like I said, just like you're reading Rutherford, and you're not just learning from patients, you're learning from books. Technical skills is the same thing. So institute this early and get it done often, and then master this. So when you get to the OR, you're not learning how to sew. I think it's a failure of our training system that we're learning how to sew in the OR. It's ridiculous. There's no need for that. There are things I cannot replicate. I can't really replicate aortic exposure, short of a cadaver left, sort of something super high fidelity and expensive. But I can easily replicate, an AV fistula, at least the anastomosis. So why aren't we learning that outside the OR? So when we get into the OR, we're doing the more complicated stuff.
Right. There are a few more questions. One from Dr. Shaw, who also says, love the idea. Is there a, quote, theory, unquote, test prior to the skills test? For example, knowledge of surgical instruments and basic OR setup, endo, open / hybrid?
There is not. And so I'm very big on, when you use simulation, what are you using it for? You can use it to teach, and you can use it to test. Often bad to combine those two with one kind of session. And it's often bad to incorporate a lot of cognitive things into a technical skills teaching program. So I think that stuff could be, and I think it's actually probably a good idea to teach all that stuff, but I think it's a separate thing, right? I think, too often we get caught up in using the simulator. I'm like, you didn't give heparin, or you didn't do this, and that's cognitive. That's learning the steps of the case, which simulation can do. But, when you're teaching technical skills, you should keep the cognitive out of it as much as possible. People don't learn that way. It's better to separate them.
There is another question from Dr. Audu. Great work, Dr. Sheahan and team. What stage of the year are the trainees tested? At the beginning, middle, or end?
So that's a good point. So we standardized that on the actual side. I veered away from the hardcore science in my presentation, but so we did that by month. So when we have, it's kind of a complicated answer, but so that's why I presented some of the answers in terms of months that they were, rather than their PGY year. When this is rolled out, our idea is that it's a rolling exam and can be really administered almost any time in the PGY year. But the goal is to have everybody finished and passed and signed off by the end of the PGY2 year. Now, we've tested people at all times, obviously, but the goal is when it's actually instituted as a program, it's something that's completed by the end of the PGY2 year.
Well, thank you for this wonderful presentation. There's a few more questions. We are out of time, so I'm actually going to move on and turn it back over to Dr. Hicks.